This content is not designed for use as a medical reference to diagnose, treat, or prevent medical illnesses or trauma. If you have questions about the diagnosis, treatment, or prevention of a medical condition or illness, please consult your personal physician.
Welcome back, everyone. Today, we're going to delve into the first of two lectures on head injuries. Most of you probably know someone who has suffered from a head injury. And recently, we've been hearing more and more about specific types of head injuries in the news. For example, there's been a lot of chatter about sports injuries and the rise of a condition known as chronic traumatic encephalopathy, or CTE. We've also been hearing about military personnel who've experienced concussions from bomb blasts. We'll cover these examples and more in our next lecture. For now, though, let's review some of the basics of head injuries. In this lecture, we'll discuss common symptoms, initial assessments, and pathology associated with head injuries in general, some different categories and subcategories of head injuries, and some of the neuropsychological deficits associated with closed head injuries, which include concussions. Some of the more common symptoms of a head injury, and this is a long list, so bear with me, include the following: a change in a person's level of consciousness, dilated or unequal pupil sizes, vision changes, so blurred vision, seeing double, being bothered by bright lights, loss of eye movement or blindness, spinal fluid, which is a thin, clear liquid coming out of the individual's ears or nose, dizziness, balance problems, difficulty breathing, being in a coma or a semi-comatose state, paralysis or difficulty moving body parts, weakness, poor coordination, slow pulse, slow breathing rate with increases in blood pressure, vomiting, lethargy, headaches, confusion, ringing in the ears, so tinnitus, or changes in the ability to hear, difficulty with thinking skills, so inability to think straight, memory problems, poor judgment, poor attention span, or slowed cognitive processing speed, inappropriate emotional responses, so irritability, being easily frustrated, or inappropriate crying or laughing, difficulty speaking, like slurred speech, trouble swallowing, body numbness or tingling, and loss of bowel or bladder control. Now that's a wide range of symptoms. The specific symptoms each person with a head injury is likely to show will depend on a number of factors, such as the cause of the injury, the brain areas involved, and the severity of the injury. Head injuries are complex and vary greatly from person to person. When people go to the hospital with a head injury, they're typically assessed on the Glasgow Coma Scale and the Glasgow Outcome Scale. Depending on the type and severity of the injury, neuroimaging scans may be conducted as well. In all head injury cases, a thorough examination of the patient takes place to help determine the extent of the injuries. Now, the Glasgow Coma Scale is used to evaluate a person's level of consciousness and the severity of their injury. Scores on this scale are used to make medical decisions and to monitor the patient's progress. 3 values are determined that are associated with attempts to elicit body movements, ability to open the eyes, and verbal responses. The 3 values are added together to arrive at a total score ranging from 3 to 15. Score values from 3 to 8 signify the presence of a severe head injury. The 9 to 12 range suggests a moderate brain injury, and scores of 13 to 15 indicate a mild brain injury. With severe head injury, loss of consciousness generally exceeds 24 hours, meaning the person is in a coma. There is no evidence of a sleep-wake cycle during this loss of consciousness, and there are generally signs of injury on neuroimaging scans. With a moderate head injury, a person may be unconscious up to 24 hours, and there may or may not be signs of injury on neuroimaging scans. And finally, for mild head injury, there may or may not be loss of consciousness. If there is, it lasts less than 30 minutes, and there are generally no signs of injury on neuroimaging scans. The Glasgow Outcome Scale, meanwhile, is a brief one-item descriptive assessment used by the treatment team following a brain injury. The scale helps to determine the next steps in a person's care. There are 5 possibilities with this scale. Good recovery, which means light damage with minor neurological and psychological deficits. Moderately disabled, so need for assistance in everyday life. Employment is possible, but may require special equipment. Severely disabled, so severe injury with permanent need for help with daily living skills. Vegetative, meaning severe damage with prolonged state of unresponsiveness and a lack of higher mental functions. And dead, so severe injury or death without recovery of consciousness. These measures, along with other assessments, will best help doctors diagnose and develop a treatment and recovery plan that best suits the patient. So, what is happening inside of the brain during a head injury? Well, we know that the particular brain areas involved will vary from person to person depending on where the injury occurs. But regardless of where, neurons and their axons are affected by head injuries in the same way. As we've previously discussed, the neuronal cell bodies of neurons make up the gray matter in the brain, so the specific cortical areas. And the neurons' axons make up the white matter, which enables different brain areas to communicate with one another. We know through research that head injuries directly affect the physical, metabolic, and functional activity of neurons in the brain. When sudden twisting and turning movements occur inside the brain, as happens with a head injury, neurons can be easily damaged and sometimes even die. When an initial trauma like this descends into a series of biochemical and other physiological responses that cause the destruction of these neurons, this process is called secondary cell death. Many times, this secondary death occurs days or weeks after the initial injury occurs. Axons can sustain structural damage as well. Think of these axons, so these white matter tracks, as roads in your town that connect different stores to each other. Normally, you can easily drive on these roads to go from one place to the other without any difficulty. But now imagine that the roads are closed off to traffic or in need of repair. It's now much harder for you to travel from, let's say, the coffee shop to the hardware store. Maybe it takes you longer to get from one store to the other. So now relate this example back to your brain. Different areas of your brain are connected through these roads or white matter tracks. A concussion causes damage to these tracks. The end result is that information can no longer easily travel from one area of your brain to the other, which can lead to a wide variety of symptoms. Moreover, sometimes a person with a head injury might appear to fully recover, then starts having seizures a year or two later. This is because the scar tissue that forms from the injury can sometimes lead to the development of seizures or epilepsy. Let's turn now to the different categories and subcategories of brain injuries, starting with the distinction between non-traumatic and traumatic. A non-traumatic brain injury is caused by internal factors. These factors include things like lack of oxygen from drowning or choking, a brain tumor, stroke, meningitis, encephalitis, metabolic disorders, carbon monoxide or lead exposure, and drug overdose. By contrast, a traumatic brain injury, often referred to as a TBI, is caused by external forces. Examples of these include falls, motor vehicle accidents, sports injuries, gunshot or knife wounds, domestic violence, military-related blast injuries, or even shaken baby syndrome. In this lecture, we're going to focus on traumatic brain injuries, of which there are 2 subtypes, penetrating and closed head injury. In a penetrating head injury, an object has penetrated the skull, so a knife, bullet, or some other type of object. Remember Phineas Gage and the tamping iron? That was a penetrating head injury. These types of head injuries are relatively rare. Most individuals experience the second subtype, a closed head injury. Here, there is no penetration of the skull, and the brain receives trauma from an impact or a sudden momentum or movement change. Blood vessels in the brain may stretch, and cranial nerves may be damaged. With this type of injury, the brain may swell, but because there is no place for it to expand, pressure builds up within the skull. The brain can then enter through any available openings in the skull, including the eye sockets. When this happens, the eye nerves compress and their functions are impaired. When one of these nerves, cranial nerve number 3, is compressed, the pupil will dilate. This is why paramedics often check a person's pupil sizes after a head injury. There are different subtypes of closed head injuries. One type, diffuse axonal injury, is caused by shaking or a strong rotation of the head, as is the case with shaken baby syndrome, or by rotational forces, such as with a motor vehicle accident. Here, injury occurs because the unmoving brain lags behind the moving skull, thereby causing brain structures to tear. This tearing can cause temporary or permanent widespread brain damage, coma, or even death. Another type of closed head injury is known as a contusion, which is a bruise or bleeding on the brain caused by a force like a blow or jolt to the head. Large contusions may need to be surgically removed. A coup-counter-coup injury describes contusions that are both at the site of impact as well as on the complete opposite side of the brain. So imagine someone gets into a motor vehicle accident and hits their head on the steering wheel. The brain will slam against the skull in their forehead, but the opposite motion will also occur where their brain slams against their skull in the back of their head. So their injuries will be associated with both the frontal lobes in the front and the occipital lobes in the back. Intracranial hematoma is a condition where a blood vessel ruptures and causes a pool of blood to form around the brain, called a subdural hematoma, or between the brain and the skull, called an epidural hematoma. An intracranial hematoma causes an increase in pressure on the brain and requires immediate medical attention. Finally, we have the concussion. Concussion occurs when a bump, violent jolt, or blow to the head disrupts normal brain function. It can also be caused by a hit to your body that's strong enough to cause your head to forcefully move around inside your skull. Concussions stretch and bruise nerves and blood vessels, can cause chemical changes in the brain, and damage neurons, impeding normal brain function. The more concussions a person experiences, the greater the chance of permanent structural changes to the brain. The most common causes of concussion include falls in people aged 65 years of age and older and children ages 4 and younger, motor vehicle accidents, domestic physical abuse, bike accidents and sports-related injuries, and exposure to explosive devices, as in the military. In our next lecture, we will more closely examine sports and military-related injuries. Symptoms of a concussion include dizziness, headaches, blurred vision, nausea, vomiting, slurred speech, appearing dazed or confused, ringing in the ears, delayed responses to questions, and potential loss of consciousness. Headaches are the most common symptom. Most symptoms resolve within 14 to 21 days, but some individuals continue to have symptoms weeks, months, and even years after the incident. Concussions, like brain injuries in general, can be mild, moderate, or severe. Approximately 75% of concussions from closed head injuries that occur annually in the United States are classified as mild, Because a concussion, especially a mild one, shows no visible physical scars, it's often referred to as the invisible injury. Many people assume that a person who experiences a mild concussion should be back to normal within days. But many times, particular symptoms linger, causing ongoing difficulties for the individual. With all of this in mind, let's take a look at 2 case studies of individuals who suffered from a mild concussion. We'll start with Paula, a healthy 62-year-old math professor, married with 3 adult children. On the day of her accident, Paula was stopped in the left turn lane of a 2-lane road, preparing to drive into the parking lot of her local grocery store. As cars whizzed by her in the opposite direction, one car started to veer toward her and hopped over the median. The car was traveling at approximately 35 miles per hour. Paula knew the car was going to hit her, but she had no time to react. The car crashed into her driver's side door, smashing the driver's side window. Luckily, she did not hit her head or experience any bodily injuries. Shocked and feeling confused, she exited her car through the passenger door and wandered around in a brain fog. The driver of the other car and a passerby stopped to help, and 911 was dispatched. Paula found she had difficulty speaking, like she was stuttering. At the hospital, they checked her out and sent her home to recover. As Paula left the hospital, she noticed the onset of a headache right behind her right eye. In the days following her mild concussion, she experienced more headaches, blurry vision, and confusion. Although the confusion subsided within a few days, the blurry vision lasted approximately 9 months, and she continues to have the headaches today, 2.5 years after the accident. They are, however, becoming less frequent. Paula had a headache nearly every day for the first year following her head injury, but now it alternates. She'll go a few days without one, then she'll get them several days in a row. Sometimes the headaches will last 10 to 15 minutes, and sometimes they'll last all day. Triggers include bright lights and weather changes, especially rain. After her head injury, she had to dim the brightness on her computer screen and replace the fluorescent light bulbs in her office in an effort to avoid bright lights. Paula's daily headaches substantially affected her life. As a professor, she could no longer grade student exams for extended periods of time without taking frequent breaks, so it took her a lot longer to get her work done. She also had to break up the time she spent on her computer. When her university changed the number of courses some faculty needed to teach from 3 courses to 4, she ended up retiring, knowing that she could not handle teaching 4 courses at once. So the head injury really affected Paula's job. It also affected her hobbies and social life. Though she has been an avid volleyball player, she had to give up her co-ed volleyball league as her physician said she couldn't risk getting hit in the head by a ball. To try and get rid of her headaches, Paula went to an array of medical professionals. She saw a concussion specialist, a neurologist, a chiropractor, a massage therapist, a physical therapist for vestibular therapy, an acupuncturist, an ear, nose, and throat doctor to see if her sinuses were causing issues. She also took various supplements and medications, including fish oil, magnesium, riboflavin, and amitriptyline, an antidepressant and nerve pain medication. The only thing that helped her was the amitriptyline, which relaxed her enough to stop the headaches from interfering with her sleep. Paula even had brain imaging scans performed, but they didn't reveal any abnormalities. The insurance company of the man who hit Paula offered her a settlement of $3,000 for her pain and discomfort. Let me repeat that. $3,000 for dealing with headaches for nearly 2.5 years so far, disruptions to her work and social life, and time spent on countless medical appointments. The insurance company wants to see objective evidence, basically abnormal neuroimaging scans. But we know that individuals with mild closed head injuries don't tend to have abnormal brain scans. I wish I could say this is an abnormal occurrence, but unfortunately it's not. Paula's case is a good illustration of someone who shows no external physical injuries. Remember, she didn't even hit her head, yet has suffered long-lasting symptoms from trauma to the brain. Our second case study is about a 49-year-old man named James. James was a professional with a well-paying job, a wife, and a loving family. Prior to his head injury, James had struggled with obsessive-compulsive disorder and depression for most of his adult life and had in recent years turned to alcohol as a form of self-medication. According to his wife Elizabeth, James changed following a concussion after falling down a flight of wooden stairs and hitting his head on a concrete floor. He had a cut above his eye that required stitches, and he was dazed and confused. After being rushed to the hospital, James returned home to recover. He took some time off work due to his inability to focus, problems with memory, and difficulty being in a noisy and distracting environments. Over the course of the next year, James had difficulties with initiation and motivation, became increasingly depressed, and had suicidal thoughts. Although he was making some progress, he was clearly different than the person he was before the accident. Elizabeth noted that he became easily irritated and frustrated and felt like he lacked purpose in his life. Soon after, COVID-19 appeared, and the need to quarantine sent him into a spiral for which he could not recover. James committed suicide in an effort to free himself from his pain and suffering. Concussions, even mild ones, affect individuals differently. Pre-existing conditions and environmental circumstances can significantly affect one's ability to recover, and in some instances, even led to a tragedy like James and his family experienced. So what are some of the neuropsychological deficits associated with closed head injuries, including concussions? There are many, and they can depend on how grave the injuries are. Severe closed head injuries can cause both widespread damage throughout the brain and focal damage to specific brain areas. Because of this, a variety of cognitive deficits can be seen in addition to motor, sensory, and emotional deficits. Most individuals with severe closed head injury exhibit a combination of problems with attention, information processing, executive functioning, and memory. Common frontal lobe deficits include a lack of motivation, poor planning and organization skills, difficulty initiating actions, a decreased ability to change existing mindsets or behaviors, trouble with abstract thinking, an increased dependence on external structure to guide behaviors and cognitions, a decreased awareness of one's own deficits, an inability to learn from feedback or mistakes, inappropriate behaviors, slowed thinking and responses, difficulty learning new information, and trouble focusing on a task, especially when other noises and distractions are present. Temporal lobe deficits include deficits in verbal and nonverbal memory. Patients with left hemispheric damage often have word-finding problems, and if they have damage to language areas, they may have difficulty producing or understanding speech. Parietal lobe deficits typically result in patients having trouble finding their way around. And occipital lobe deficits can cause visual field defects or even conditions known as visual agnosia and prosopagnosia, which we'll talk about in the next lecture. In addition to cognitive difficulties, patients may experience psychiatric and psychosocial disorders. These can include personality changes due to frontal lobe involvement, mood swings, irritability, aggressive and violent reactions, and difficulty controlling inappropriate conduct. More long-lasting consequences include depression, suicidal thoughts, fatigue, loss of confidence, self-esteem, independence, changes in sexuality, and family disruption. These long-term issues are primarily the result of trouble adjusting to one's new physical and psychological self. So those are the deficits we tend to see in more severe closed head injuries. Mild closed head injuries are typically associated with cognitive issues, including trouble with attention and concentration, difficulty learning new information, trouble following conversations, brain fog, word-finding problems, and slowed reaction times. In day-to-day life, patients often report having to put more effort into learning and recalling names of new friends or facts they are trying to memorize. They become irritable in noisy environments, and if their work requires concentration, memorization, or processing new information, they tire very quickly, develop headaches, and may fall behind. Ongoing physical symptoms can include headaches, post-traumatic amnesia, meaning an inability to recall how the injury occurred, nausea, dizziness, sensitivity to light or sound, and fatigue. Emotional issues include feelings of sadness, irritation, and anxiety, feeling emotions more acutely, changes in personality, and increased impulsivity. Finally, sleep issues include sleeping more, trouble falling asleep, trouble sleeping soundly, disturbances to the sleep cycle, and not feeling rested after sleep. If symptoms continue for weeks or months, patients may lose confidence in their ability to work and maintain relationships, resulting in frustration, irritability, and lowered self-esteem. As you can see, head injuries are complex and can affect people in many different ways. In our next lecture, we'll investigate two visual conditions, visual agnosia and prosopagnosia, that can result from head injuries, as well as sports injuries that can lead to chronic traumatic encephalopathy and head injuries caused by bomb blasts. We'll also discuss how head injuries are generally treated and whether there are any new treatments on the horizon. See you then!